I think we can go to the next last session for this meeting, and actually there will be the hot topic of this meeting in the COVID era and the echo and the imaging from the COVID era, and here will be the next presenter who will be online. This is the presentation of the professor Bernard Cousins. He was so kind to send his presentation pre-recording, and we will start with a short presentation of the Professor Cousins.
So welcome everyone. So I was asked to address the issue of imaging COVID-19 patients with myocardial injury. And so first of all, I want to ask you not to forget the patients, non-COVID patients having some cardiovascular disease. We see indeed that mainly patients with coronary artery disease receive less angiography. So if you look at the right side of the panel, more than 40 patients, more than 40% of the patients are not receiving any coronary angiography. So this means that probably one part of the patients are not coming, but also that we have to reallocate some resources to other activities like COVID. But it's not a reason to forget these patients because they can also have myocardial injury due to coronary artery disease. More importantly, there are also other cardiovascular disease that are recognized as associated with troponin elevations. And I'm thinking personally to endocarditis, for example, which is in fact a disease that will mimic in some way the COVID infections. But if these patients are not treated, the prognosis is even worse than COVID patients with a pulmonary infection. Therefore, I think it's important not to focus too much on COVID patients and not to forget that there are other causes of increase in troponin and myocardial injury during the COVID-19 era. Saying that, it's even more complex because we know that, COVID-19 and myocardial injury coexist, of course, but there are a lot of different mechanisms leading to myocardial injury. And more importantly, there are different types of phenotypes that are associated to myocardial injury in COVID-19. So we have mainly three families. The first one is myocardial infarction. The second one is heart failure. And the last one is arrhythmias that can be threatening. So it's important to, of course, to know that and to integrate the clinical data to what you will get from information from biomarkers and imaging to give the appropriate treatment to these patients and to be aware that these different phenotypes can also coexist. So a brief word about the role of imaging in this pandemic situation. We have issued recommendations regarding safety, and I think it's important to keep that in mind, but to make it short. So the main messages are that you have to go for imaging only when it's needed, and you have to provide the lowest risk of contamination to the healthcare personnel and to the patients. Therefore, you need to choose the best technique for the best results. So when it's appropriate, and therefore to go for the best efficiency. That's the main message of this paper. Keep it safe. No, saying that, when to go for echocardiography or for imaging in COVID-19 patients with an increase in troponin? Is that required in all patients, yes or no? The answer is clearly no. Certainly, if you keep in mind these safety issues. So you have not to go for imaging if your patient at admission is a low-risk patient, or if the patient has a low level of troponins that remains stable. In this case, you don't need cardiovascular imaging. At admission, you need to go for cardiovascular imaging if you want to stratify the risk of your patients. And then when your patient is hospitalized, then imaging plays an important role, again, in the one having an increase in troponin or high risk, because this allows you to have some data regarding the prognosis and especially the occurrence of cardiovascular events. So in summary, when to go to cardiovascular imaging in patients that are now hospitalized? Well, in fact, when you think about a chronic myocardial injury, meaning that there is a low level of troponin and the delta between two control of troponin is less than 20%. So mainly chronic heart failure, cardiomyopathy, hypertension, CKD, and so on. In the other causes, ischemic or non-ischemic myocardial injury should be assessed using cardiovascular imaging. But it's quite complicated to know which technology to use during this pandemic, and therefore we also issue another recommendations to guide you a little bit in this setting. And as you can see, echocardiography is a first-line examination in most of the clinical scenarios. Okay, so you are at the right place today. But in some other circumstances, you should eventually go for another technique. If you suspect a lung embolism, you have to go for CT. If you suspect a myocarditis, you have probably to go for CMR in most of the cases. If you suspect an acute coronary syndrome, you have to go for invasive angiography. So now there is some controversy about what technique you should use. Do we have to go for POCUS, or do we have to go for full comprehensive echocardiography? There's enough evidence to say that POCUS is in most of the case enough. And so if you apply this seven views protocol, in most of the patients, you will get enough information. Okay, if not, you can go for comprehensive echo. Of course, there are also some publications showing that using advanced echo, and today we will talk about advanced echo and strain and right ventricle assessment, of course you can go for it. But in most of the case, it's not suitable, especially in critically ill patients. You don't have EKG, you don't have enough quality to make it. And if the quality is not good enough, you can think about contrast echo in some way, but being aware of the complications, especially in the patient with assist device of contrast agents, and therefore this should be used carefully. You will have a complete, I think, presentation on the role of echocardiography and what you can expect from this. But you can see that, interestingly, the right ventricular dysfunction is quite often present, much more than left ventricular global dysfunction. And that this is the main purpose of my message. Don't look only at the left ventricle. There are enough literature to show that if you have a dilatation of the right ventricle, if you have a right ventricular dysfunction, your patients will have a poor prognosis. And therefore, it's important to look to the both ventricle, because the mortality is linked to also the dilatation of the right ventricle. Now, in case of suspicion of CAD, as I always mention, integrate the clinical data to the use of imaging. And that this is an adaptation of the chronic coronary syndrome guidelines of the ESC. So look at the clinical likelihood or pretest probability regarding CAD. And in function of that, you choose the best way to image your patients, or even not to image your patients if this clinical likelihood and pretest probability is low. And of course, as I mentioned earlier, in some patients, you will need to go for coronary artery angiography immediately if the suspicion is high. But you have to remember that in many patients with COVID, the findings are quite atypical. You can have a lot of thrombi and normal epicardial arteries. You can have Takotsubo cardiomyopathies, or you can have Minoka. And of course, this is the follow-up that will give you the answer. But in any case, you need, of course, to monitor your patients and to treat them appropriately. We have seen a lot of myocarditis. And in that circumstances, echo can provide some information in case of global dysfunction. Strain can be useful because then the distribution of the abnormalities is not corresponding to the coronary artery distribution. But anyway, myocarditis is better detected by CMR, but you have to know that some of these diagnoses may be missed if you are going for CMR too early. And if it's negative, do not hesitate to repeat it after 4 days. No, we have been speaking about a patient that are hospitalized, but some patients, of course, should be followed after discharge, because there are some lessons to be learned from the flu pandemic. We know that many patients having a flu will die more of cardiovascular complications within 6 months, 1 year after the acute infection than from lung complications. And probably it's the same with COVID. And indeed, this seminal paper published recently by Puntman from Austria is showing that many patients, 78%, will have after recovery a cardiac involvement. And even 60% will still have ongoing myocardial inflammation. Therefore, this is probably much more frequent than we think, and we should follow this patient over time. A specific subpopulation is also of interest. These are the athletes. It was interesting that in a college in the US, they tested systematically all the athletes before they go back to retraining, because of course we know that if the patient had a myocarditis, he's at risk to do some arrhythmias, to have some sudden cardiac death problems during the retraining. So we have also to avoid any effort in patients with pericarditis. So therefore this is of crucial importance. And you see that it's not negligible. In the overall group, 27% at pericardial involvement and around 17% at myocardial involvement. So it means that this is a matter of concerns, and you have also to have a good strategy to test the patients that want to go back to the sport and to be retrained, and especially in athletes. And even more difficult is that there are some confounding factors related to the remodeling in athletes. Therefore, I really recommend to read the consensus, the expert consensus, providing some red flags to increase awareness regarding these patients. So saying that, I will conclude by saying that, of course, imaging is crucial. Echocardiography is the first line examination in COVID patient with myocardial injury, but please do not forget to integrate that into the clinical context. And finally, do not forget the patients having some symptoms mimicking, of course, the myocardial injury related to COVID, but not having COVID. So once again, enjoy your Congress and congratulations to the organizer.
So we can move to the next one speaker, Kostas.
Yes, we have to say that we are honored that Professor Cousins gave this lecture for us. And of course, we have two more speakers. Professor Economidis from University of Athens, a really experienced echocardiographer and one of my mentors. And Professor Economidis, we would like to hear from your side about what kind of abnormalities you face in COVID cases, as your hospital has been a COVID referral hospital, and would like to have a look at your personal experience.
Thank you very much, Dr. Papadopoulos. Thank you, Professor Christova, for this kind invitation. It's been an honor to participate in this very interesting and well-organized course of ECHO. And of course, we all know about this pandemic that counts up to now to 2 million global deaths. And this is the case also in Greece, where we have about 150,000 COVID cases diagnosed, but 5,000 deaths up to now. We all know the pathobiology of SARS, the spike protein priming the TMPRS, and then connect to the ACE2 receptor, causing cell infection, and by that way it gets into the cell, causing an inflammatory disaster. We all know that when we have a virus infection, no matter if it's COVID or flu infection, we can have either direct effects because the virus itself hits the cardiovascular system. There is a surge of pro-inflammatory cytokines that they have a negative action on the heart. They cause hypotension, tachycardia, and maybe sudden cardiac death and myocarditis per se. However, they increase metabolic demand of a viral infection. The reduction in the cardiac reserve may either destabilize an already present cardiovascular disease, or may reveal the presence of subclinical cardiovascular disease like coronary artery disease. So we have either a direct action or a secondary action because of the presence of comorbidities. Now, there are several studies showing that in COVID patients, we can have acute myocarditis, we can have DVT leading to pulmonary embolism, acute cardiac injury, and even ischemic stroke. And what are the mechanisms? Are the hypotension, the hypoxia because of the lung disease, the coagulopathy. We should face this infection as an endothelitis, the adrenergic stimulation, the cytokine storm, and all this may lead to type 1 or type 2 myocardial infarction. They may act on the myocardial cell and cause acute myocarditis, and of course, as an endothelitis, because of the acute inflammation and the large inflammatory burden, we may have coronary microvascular ischemia and MINOCA, and of course, stress cardiomyopathy. There are several case reports regarding COVID infection and coronavirus myocarditis, tachytubocardiomyopathy, ST elevation syndromes, and massive pulmonary embolism and thrombus in transit in cases of COVID infection. Now, in this very elegant study, they have seen patients with COVID that developed a new onset ST elevation myocardial infarction, and again, you can see that there were several comorbidities, several risk factors that may have developed athermatic plaques that under the stress of an infection gave an acute coronary syndrome, and these were hypertension, diabetes mellitus, and CKD. Also, when they did coronary angiography, in about 40% of these patients, a culprit lesion was not identifiable, again showing that there may be coagulopathy, thrombi formation that has been released afterwards, or there may have been a MINOCA syndrome. This is the reason that the thrombolysis is not justified in these patients. Of course, thromboembolic events are common, but more or less 31% in ICU patients. And of course, fulminant myocarditis case reports have been shown either in men or women, and usually this fulminant myocarditis are in need of intra-aortic balloon pump and ECMO and vasopressors. However, in autopsy studies, despite the detection of an increased viral load in almost 41% of COVID patients and the increase of 6 pro-inflammatory genes, there was no association of inflammatory cells influx, and this study actually indicates and questions the role of COVID as one of the major viruses that can cause a direct myocarditis. So it is possible that the myocardial injury in COVID patients is done through endothelium or through damage of the coronary vessels, rather, or the coagulopathy than the actual effect of the virus on myocardial cell. Now, this is a clinical case from our institution, 45-year-old male with severe COVID pneumonia, hospitalized, but actually he did not need mechanical respiratory support during his hospitalization. He had no symptoms like chest pain. However, he had sinus tachycardia, and at admission there was a troponin I rise, also combined with NT-proBNP rise and increase in T-dimers. This is his echo, actually a good RV function, a good LV function, nothing actually prominent, no significant wall motion abnormalities, and ejection fraction of about 55%. And this is the E to A ratio, somewhat lower E than A, but nothing actually significant in TDI. But however, when we did the strain, we could see that there was a significant lower strain values, as you can see with the arrow, at the area of the posterior wall. And this is the bullseye showing again low strain values in the posterior, infero-posterior wall. After his discharge from the hospital, an MRI was performed, and again you can see here late gadolinium enhancement in the area of the posterior wall, and again here where you can see the arrow, again there is late gadolinium enhancement indicating the presence of an inflammatory insult during probably because of the COVID infection. Now, this is the echo, again, a good LV function at the time that the MRI was performed. And again, you can see in the global, the GLS, in the posterior wall, a significant reduction from -11 at admission to 3% about a month after his discharge from the hospital, coinciding with the evidence of the late enhancement in CMR, and again suggesting that this COVID infection had some effect on his myocardium. This is another patient, 50 years old, 3 months post-COVID hospitalization, no CVD risk factors like diabetes or hypertension or any kind of medication before. However, when we controlled his coronary flow reserve after adenosine, you can see that the velocity was 0.33, went to 0.60, given a CFR or approximately 2. We did a flow-mediated dilatation study after hyperemia of 2%, quite low, and a pulse wave velocity of 12.8, while the blood pressure, as you can see, was not significantly elevated. And you can see here his normal ejection fraction. However, the global longitudinal strain was somewhat impaired, 18%. The values for his age should be around 20%, indicating again a relation between endothelial dysfunction, vascular dysfunction with a reduced global longitudinal strain, and again signifying the presence of endothelitis causing a damage in the myocardium and a reduced LV performance. Plus, echocardiography has a widespread availability. It's portable, easy to store images, relatively easy to disinfect handheld echo devices, and of course, we need to have a focused or POCUS approach, as the previous also speaker said, and we have to bear in mind, however, not to overuse it and not to use our echocardiography resources in the course of the pandemic because we need them. Now, when there was a global evaluation in patients with COVID with echocardiography, at least 55% had some kind of abnormalities in echocardiography, and this was 40% for LV and RV abnormalities. However, clinically, only 3% had evidence of myocardial infarction, myocarditis, or tachytubal. So, what are the predictors of abnormal left ventricle? These are a suspected left heart failure, that is symptoms of heart failure, chest pain, typical chest pain, anginal pain, and troponin elevation or BNP elevation, suggesting that there may be an abnormal left ventricle found during echocardiography. Similar findings are for right ventricle, again, symptoms of right heart failure and a severe COVID pulmonary infection. Now, half of the patients revealed abnormalities, and imaging changed management in about 1/3 of patients. Now, what happens in patients that are hospitalized in ICU? In this interesting study, they have checked preload indices like IVC diameter, E/E ratio, indices of LV contractility like ejection fraction, and even ventricular arterial coupling, which is very easily assessed during echo and Doppler echo. They used LV afterload and RV function markers like TAPSE, and they used indices of global function like velocity time integral and the cardiac index. Now, using these simple indices, they could change the therapeutic management of the patients. And more interesting, they could administer vasopressors when needed, they could administer fluid, they could change the respiratory settings according to the findings of these simple echo markers. Acute myocardial infarction, again, was found, actually diagnosed by wall motion abnormalities and troponin, and again, gave the opportunity to improve the patient's management. Now, by combining all this data, we have published from my institution this very short and easy algorithm suggesting that in patients with COVID infection that are in need to be hospitalized, if there is hemodynamic instability on admission, of course, cardiac POCUS should be used to find LV or LV dysfunction. If patients are stable on admission, then an ECG, troponin, anti-BMPD dimers, and chest X-ray should be performed. If more than 2 are abnormal, then we should perform TE to check ejection fraction, wall motion abnormalities, LV filling pressures by E/E ratio, GLS, right ventricular size and fraction, measures the systolic pulmonary pressure, and check markers of pulmonary embolism like IVS flattening, 60-60 sign, and McConnell sign. If just only one is abnormal, then we should consider transthoracic if there is clinical suspicion of pulmonary embolism, acute coronary syndrome, or acute viral myocarditis, and again perform a comprehensive study. But if we do not find anything abnormal, we should defer TE. And after a monitoring period of 15 days, and only if new symptoms are developed, then we should, or biomarkers are increased, we should perform a TE study just to protect the cardiac, the resources, the echocardiographic resources of our department. Again, like the previous speaker, very important to check what to do with the competitive athletes. And in this case, in COVID positive patients, after their 14 days, if they are not hospitalized, two-dimensional echo has to be performed, and then they can go back to their practice, to their activities, athletic activities. If they have significant symptoms and are hospitalized, again, we should consider cardiac imaging in these patients. Thus, I would like to conclude that the cardiovascular manifestations of COVID-19 disease can either be clearly identified by symptoms, ECG, and all these equipments we use in admission and by examining the patient, and of course require specific treatment. However, subclinical cardiovascular disease may be present in the form of myocardial injury and subsequent LV-RV dysfunction observed during echocardiography. Echocardiography is the invaluable tool to assess these patients with clinical suspicion of cardiovascular complications and can aid and guide treatment in critically ill patients in ICU. Follow-up echo is essential for guiding return to exercise for athletes. And here I would like to thank you very much for your attention and for your kind invitation.
Thank you, Professor Economidis, for the interesting presentation and for your expert opinion about this topic. Here is one question from the audience. How do you see the alteration in echo in patients with mild symptoms of COVID?
Actually, one would expect to find, as I say, some abnormalities, even with global longitudinal strain, which is the most sensitive to define subclinical involvement in this. However, this is needed only when we have troponin elevated or we have some changes in an ECG. That is when we should further check this patient, not when it has only mild symptoms and no evidence of increased biomarkers or ECG changes.
Professor, I've come across with a case report showing the role of myocardial work in detecting subclinical dysfunction in cases where GLS was normal. Do you measure it routinely in your lab?
Actually, there is a lot of work and we are participating in that. What happens after the COVID infection? As Professor Kozins mentioned before, we know that infections, even pneumococcal infections or viral infection, may affect endothelium, may be the cause or the triggering factor of coronary artery disease. So yes, even after the COVID infection, there may be some kind of involvement. Myocardial work is also a very sensitive marker showing this ventricular arterial coupling and the effects that the COVID infection may have on vascular function, and vascular function affects myocardial function because these things go together. So if vascular aortic function is impaired or even peripheral arterial arteries are impaired, that directly affects myocardial function. This is the so-called ventricular arterial coupling. And as it seems that COVID disease is endothelitis, is also a vascular disease, then we expect that the effects on vascular function will eventually cause an effect on myocardial and cardiac performance.
Okay, Professor, thank you. So as Professor Christova, you can see that we are coming towards the end of this meeting, and almost 300 people wait for Luna Gargani to give the last but not least lecture. And we would like to thank you for the honor to attend and participate in this echocardiography meeting. And your topic will be B-Lines lung ultrasound in COVID era.
Okay, so thank you very much, Kostas. Thank you, Krasimira. I also congratulate for the great success of this meeting. I've been following all the presentation, has been great. So lung ultrasound in COVID-19, it's a very popular topic at the moment. And unfortunately, the COVID pandemic has raised the awareness about the usefulness of lung ultrasound. And this is testified by the number of papers about lung ultrasound that we may find, for example, in PubMed. You see there is a gradual increase in the number of papers, but then in 2020, we have a huge spike, and this is due to this COVID effect. And indeed, lung ultrasound can be useful in many different clinical situation in patients with COVID-19, from emergency department for the diagnosis to internal medicine ward to the intensive care units, and also home. For example, in Italy, but I believe also in other countries, some specific services have been developed with doctors and sometimes also sonographers going directly to the house of the patients to assess with lung ultrasound the probability of the presence of a COVID-19 related pneumonia. And this is a very effective way to spare the traveling of patients and to reduce the risk of infection. So actually, lung ultrasound in COVID-19 can be used for the diagnosis, monitoring, and prognosis. But for diagnosis, we have quite solid data now. We have some nice data about prognosis. We still don't have so much data about monitoring. And that is why my presentation will focus mainly on the usefulness on diagnosis. And again, we have quite many papers at the moment on the use of lung ultrasound for the diagnosis of COVID-19, but maybe this is one of the most complete and most recent. This is a paper from the group of Le Molinette Hospital in Turin on 218 patients. And as you can see, the sensitivity and specificity of the clinical evaluation only to diagnose COVID-19 is quite good, not so bad, but this is significantly increased if you combine clinical and lung ultrasound assessment. And it's very important to underline that you don't have to use lung ultrasound alone, you have to integrate it with the clinical evaluation. But how to use this exam and how to do it in a very practical way. So actually, when you have to check a patient with a suspicion of COVID-19, the examination of the chest is a bit more complete compared to what we do, for example, in heart failure, because we have to scan the anterior, the lateral, as in heart failure, but also the posterior chest that we usually spare in heart failure patients. So don't forget to check also for the posterior chest. And we have to go through all the intercostal spaces as we usually do with all the lung ultrasound exams. The convex probe is the most universal and maybe the best one to use. But if you have a cardiac probe, because we are cardiologists and we are doing the echocardiogram in our patients, it is absolutely fine the same. You can use your cardiac probe. You have to set the gain, to adjust the gain and set the focus on the pleural line and adjust the gain to optimize the pleural line. This is important to have a better visualization. And what can we see? So actually, the main sign of COVID-19 interstitial pneumonia are the B lines. And B lines can be either separated, as in this case, which is what we usually see in heart failure, but they're often also coalescent, as you can see here. And when you have these band of very echolucent coalescent B lines, like in this case, that sharply change into a normal pattern of aerated lung, what we call a spared area, this kind of picture has been named the light beam. So actually the light beam is a band, a very bright band of coalescent B lines determining a spared area, so sharply changing into a pattern of normal lung. And this is another example of coalescent B lines yielding a light beam. And another one here. So this is a name that has been given to underline that this is quite a typical sign of COVID-19, but it is not specific. You can find it also in other situations. And then the pleural line, you can have either a regular pleural line, as we usually find in heart failure, but you can also find an irregular fragmented pleural line, as in this case. And we can see some small peripheral consolidations, as this small consolidation here. And again, you see a lot of B lines, a lot of coalescent B lines. And you can also see some larger consolidations, but these are more rare, and usually they are you can visualize them in the more advanced phases of the disease. So it's quite rare to see them at presentation in a patient who has symptoms since a few days. Okay, so what can we do with these signs? We can distinguish some pattern of probability of having a COVID-19 related interstitial pneumonia. And we may have a high probability lung ultrasound pattern when we have all the typical signs that are bilateral and multifocal. This is the most typical, so we call this pattern high probability pattern. But we can also have the typical signs of lung ultrasound, but not bilateral and not multifocal. So in this case, we call this pattern an intermediate probability of pneumonia. We can also have a low probability of pneumonia when we have a normal lung at lung ultrasound, or if we just see only a couple of B-lines, and we may have an alternative lung ultrasound pattern that is a pattern of something else, showing a different situation from what we are seeing. Then we have to establish the clinical phenotypes that we are facing, that we are seeing in that moment. We may have a mild phenotype when we don't have respiratory symptoms. I'm sorry. We may have a severe phenotype when we have respiratory symptoms. So if you have dyspnea and if you have also objective desaturation, and we have a mixed phenotypes when you have a concomitant pre-existing cardiopulmonary condition. So these pre-existing conditions may impair a little bit the visualization of the COVID-19 pneumonia. So, for example, this is a typical pattern of high probability pneumonia. As you can see, the typical signs that are also bilateral and multifocal. This is an intermediate probability. So we have some typical signs, but they're only monolateral. They're only on the right side. So this is what we mean for a high probability pattern, intermediate probability pattern. And then we have a low probability pattern, so you have actually a normal lung ultrasound exam, and alternative patterns may be different. For example, in this case, we have a pattern suggesting a cardiogenic pulmonary edema with B-lines homogeneously distributed all over the chest with a regular pleural line, without consolidations, without irregular pleural line. So we tested this approach in a multi-center study on 20 hospitals in Europe and in the US. And what we found in about, in almost 1,500 patients is that we have quite a high sensitivity of lung ultrasound when we use the high pattern and intermediate pattern together, considering them both as positive exam. So in the overall population, the sensitivity is 90%, but it's higher when the patient is sicker. So in the mixed phenotype, the sensitivity raised to 94%, in the severe phenotype to 97%, and in the subgroup of patients with respiratory failure, the sensitivity of lung ultrasound is actually 99.3%. In patients with a mild phenotype, you should use the high pattern, not the high and intermediate together. And in this case, the better use of lung ultrasound is to rule in the COVID-19 associated pneumonia with a specificity of 94%. And we also tested the inter-rater variability among all the different centers. And as you can see, the average intra-class correlation coefficient was very high. So this is an example of a patient was seen at the first day at admission, the 17th of March, and this is already a high probability pattern of COVID-19 with B-lines all over the chest, the light beams, some initial small peripheral consolidations, and just after 4 days, the patient deteriorated a lot, and we have another typical picture of COVID-19 pneumonia, but the typical advanced picture of COVID-19. So here we have much more subpleural consolidations. We start to have also larger consolidations. The B-lines are even more numerous, and the pleural line is more irregular. Then we also have some data about prognosis. For the prognosis, it has been used this lung ultrasound score, considering 0 as a normal lung, 1 when you have separated B-lines, 2 when you have coalescent B-lines, and 3 when you have a consolidated lung. And with this score, you can see that you can have a very good stratification of prognosis, both in terms of mortality, the panel A, and both in terms of mortality and the need of mechanical ventilation in panel B. So lung ultrasound can be also used to stratify the prognosis of COVID-19 patients. So some limitations. Lung ultrasound, generally speaking, is an easy examination, but this exam is not for novice sonographers. You need a little bit of experience, especially because the pattern is patchy, so you have to scan the whole chest. If you have to see cardiogenic pulmonary edema, that is much easier because it is a homogeneously distributed pattern. In this case, you need to be a little more skilled, but again, it's not so difficult anyway. And even if it is lower than in other techniques, there is some risk of spreading infection. So we have to remind that even an ultrasound exam should be done only if the results can impact the management. And another 2 points to be reminded are the distance from symptoms onset. And we have seen that in general, the performance, the accuracy of lung ultrasound changes according to your clinical picture, so according to the symptoms you have, and can also change according to the distance from symptoms onset. And of course, we always have to integrate this with the overall picture. We repeat this hundreds of times, but it is so important that it's worth repeating it. So in conclusion, we can say that a standardized lung ultrasound protocol combining the ultrasound probability patterns of COVID-19 pneumonia with clinical phenotypes in patients suspected of COVID-19 is feasible and reproducible. In these patients, lung ultrasound is very sensitive in ruling out the interstitial pneumonia with increasing values, with increasing symptoms. So we have seen that sensitivity raises when the patients are sicker. If you have patients with mild symptoms, a lung ultrasound here is very specific, not very sensitive, but it is very specific to rule in the interstitial pneumonia. And the detection of an alternative pattern can suggest an alternative diagnosis, especially in patients with respiratory failure. So this approach may be useful for rapidly guide the management and allow for a wider use of hospital resources, especially during a pandemic surge, and may even represent the only available tool in scarce resource areas. So in general, it can speed up the triage of patients, and in places where you don't have anything else, it can be the only diagnostic tool to understand if the patient has interstitial pneumonia due to COVID-19. If you want to see something more about lung ultrasound and COVID-19, there are a couple of tutorials on YouTube. Actually, there are plenty. These are the ones that I did, or you can find some videos on lung ultrasound on openlas.com. And I thank you all the people who were with me in these difficult months, and I thank you all for your attention.
Thank you, Luna. That was great. You are an expert of the field. I would like to ask, who should perform the lung ultrasound? Cardiologists, radiologists? Because in my hospital, even pneumologists perform lung ultrasound. So
this is a very important question. This goes to the heart of the philosophical meaning of point of care echo. So the examination should be done by anybody who can do that. But if you ask me, should be a pneumologist or cardiologist or a radiologist, I would tell not the radiologist, but not because they cannot do that. But this is not a diagnostic test as a chest X-ray or a chest CT. This is an extension of the physical examination, a huge extension of the physical examination. It should be done from the doctor who knows the clinical picture of that patient. Otherwise, all the advantages of having a bedside examination, a point of care approach, are quite lost. So this is something we have to do, not the radiologist.
So only clinicians, because it fulfills our examination.
Yeah, yes, and you can also have a sonographer to do that, but of course the sonographer has to be close to the clinician to integrate the pattern with the clinical picture, because otherwise these are artifacts. I mean, it's a field of artifacts. If you don't correlate it with the clinical picture, you may really go very wrong even if it's easy and also to be interpreted.
Thank you, Luna. It's a very interesting topic. I really hope that the people will enjoy everything. There is one question from the audience. Which type of transducer is optimal for lung ultrasound? I think your presentation you show it, but maybe
the best one is a convex probe. But you can absolutely do a fantastic lung ultrasound with a cardiac probe. You may change a little bit the depth. If you have a huge patient, you go deeper with the depth. If you have a thin patient, you go with less depth, but it's the same rules you would follow for echocardiography. So if you have to buy a machine only for lung ultrasound, convex, but if you have the cardiacs, it is absolutely fine. You can see everything very well.
Can we use the focus to follow up the patient for after the therapy?
Yeah, I mean, this is a hot topic. There are not so many data. We have used it to follow up patients, and we can see changes after mechanical ventilations, after drugs. The only thing here, I didn't show any data because if you ask me, when do you have to repeat the examination to have meaningful information, I cannot answer that. Because we have seen lung ultrasound anticipated the clinical changes of patients. But still, these are not patients with heart failure or bacterial pneumonia. So every exam you add, it is a risk for the operator. So at the moment, we have to be very careful to use it for the monitoring because it would mean to do a lot of examination to the patients. And I think that if we don't have solid data to show us that this kind of monitoring can improve the prognosis or reduce the time of hospitalization, we have to be careful to repeat it too many times. Because it's good, but even too much of a good thing can be bad.
Thank you so much. It's really appreciated for your opinion. Kostas, you have questions or not?
No questions.
No? Well, to go to the full conclusion for our meeting, I really was very happy and thank you, Kostas, for your collaboration and very good work that you make. I hope that our audience was very happy from our presenter, from our host, from our people that give everything to have this very good meeting today. And I would like to thank you all presenters that they make everything that was possible for this online meeting to be so very successful. Thank you for our sponsors from the pharmaceutical industry and the General Electric also, and for your hospital that was very kind to be also host for this meeting. I think we could be able to continue this collaboration in the near future and to give possibility this meeting to be every year for everyone, and maybe the next year we have the possibility to have personally host the meeting on face with our audience. Thank you once again, and thank you for all audience attendance, and especially for the girls of the Congress Management Company that they was very helpful for us.
I would also like to thank the organizers for this great meeting, and you as well for the collaboration. I hope that all attendees enjoyed the lectures. We try to do our best. Hopefully next year we'll be all together in rooms showing with physical presence and enjoying all these topics. And Krasimira, one comment from Dr. Bardeleben. He's right now the editor-in-chief of Echocardiography Journal, and I happen to be associate editor, and we invite people to submit original articles or review papers that will be given extra consideration for publication in this journal. I would like to thank you all again for attending, and we have 250 people that late time, and we hope that we will see you all again soon.
Thank you so much. Thank you.
Thank you.
Have a nice evening and take your
Have a
rest.
nice rest of weekend to all.
Later, maybe.
Във времена на несигурност се обръщаме към най-сигурното нещо, което съществува. Науката. Науката може да пребори заболяванията, да открива лечения и да побеждава пандемии. Правила го е преди, ще го направи отново. Защото когато се срещне с ново предизвикателство, науката не се отказва, тя атакува и задава въпроси, докато не намери отговорите. Това е силата на науката. Затова даваме тласък точно на науката и я развиваме. Нашите проучвания, експерти и ресурси, всички усилия са насочени към развитието на потенциални терапии и ваксини. Другите компании и академичните институции правят същото. Цялата световна научна общност работи заедно, за да се справи с предизвикателствата, и всички ние използваме науката, за да помогнем това да се случи. Защото ако науката спечели, печелим всички.